And so I'll start with Smita, Dr. Pakhale, and ask you to start by just giving us a brief introduction and situating yourself in your space and place. So over to you.
Unmute first. Thank you, Claire, so very much. I mean, really immensely thank you for organizing this and very important topic in a very timely manner. So thank you for doing that. And, you know, I first would like to acknowledge the territory we are on, the Algonquin Nation, the stolen land, paying rents to the wrong owners. So I really am grateful, all the Indigenous people, and we have so many of them partner and we work together at the Bridge Engagement Center. And I would like to bring attention to the word partnership and not engagement, not mere engagement. And that's what we try to achieve at the Bridge Engagement Center by working together and bringing the power imbalances down as much possible to co-create the knowledge together with people with lived experience. And when I say people with lived experience, I am saying people who are homeless currently or experienced homelessness in the past or insecurely housed or those who are low income racialized minorities, including our indigenous populations. So that target population we partner with by selecting community peer researchers from the same population who are trained on the projects and protocols, etc. But we sit at the table and design questionnaire. The questions, research questions are coming from them. And then we design the methods together around recruitment, retention, what could be the strategies, because what they know, I cannot even begin or fathom to say that I know. And that kind of lived experience we bring at the table, and then they implement the project by recruiting, consenting, administering the survey, data entry. They are even engaged in data analysis, data cleaning, and part of our writing team, co-authors, and also on our grants as co-applicants. So that kind of a partnership from A to Z, from beginning till the end, that's what we try to live at the Bridge and co-create the knowledge. And that kind of a partnership, I think, of removing the barriers and bringing the power down is what we believe is at the core if we want to make equity our new normal. And when I say equity or new normal, that whenever we are talking about recovery, whatever program they may be, education, kids education, entertainment, business, economy, we need to make that equity as new normal by creating that kind of partnership. So I would stop there, and I hope we further our discussions on those fronts, but that's what we try to live at the Bridge.
Thank you, Dr. Pakhale. Those are excellent opening words, and I really like those. Equity, our new normal. I think that is that's a really great way to sort of set the tone for today, but also to see ourselves as we move into the future. So Kate, over to you. How, and I'll let you introduce yourself, of course, but how have you, or how do you bring the voices, and in some ways you are the voice of the community in terms of where you sit, and why do you think that community engagement, community partnership is so important in this time? So Kate, over to you.
Yes, thanks, Claire. And thank you, Smita and Bonnie, for being here alongside me. I'm coming to you today from Treaty 13 territory in the city of Toronto, where I live and where I'm a member of the Board of Health. This is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe people, and now Mississaugas of the New Credit, and is home to many, many diverse First Nations, Inuit, and Métis people from all across this land. I do wear a few different hats, as Claire mentioned, but I'm here today primarily to talk about my role as a public member of the Toronto Board of Health. And so boards of health across Ontario are structured quite differently in different communities, and they all look a little bit different and have different relationships with municipalities, for example. But in Toronto, it's more or less embedded into the city structure. There are 6 city councillor members, 6 public members, and a member that represents, is a trustee from education. And actually in practice, we have 5 community public members and 2 from education. So one of those public members is from the Catholic School Board and one from the Public School Board. And so this is unusual because if you add together the trustees and the public members, we outnumber the politicians. And so it's a unique circumstance, and in many ways, I think is, went a little bit under the radar when it comes to the city's public appointments process until COVID-19. And now the Board of Health has really become recognized for playing a strong leadership role in the COVID-19 pandemic. And I would argue that that is in large part because we do have public members. We're not swept under the carpet of regular municipal governance. So in some cities, for example, the Board of Health is just equal to the City Council, identical in composition. But in our board, we're able to put matters on the agenda that matter to community. And for me, because I happen to have this connection with community agencies working on health equity, working on community social determinants of health at the neighborhood level here in the city of Toronto and across Ontario, I'm able to bring some of that community perspective, both from myself as a public member, but also from the expertise of community agencies, who in turn are informed by the expertise of their communities themselves. They're governed by communities, they're led by communities, and they have the trust of communities, which is such a critical component in the time of COVID-19, when we have, what the research calls a syndemic, where COVID-19 as a pandemic intersects with other pre-existing social and political and economic conditions that are legacies of colonialism and of institutional approaches to public health. So hierarchical approaches or one-size-fits-all approaches, neither of which have proved particularly useful in the time of COVID. But what's really proved useful, particularly for those communities who have been disproportionately affected, is this bottom-up grassroots approach. So I was really proud to be part of the board this year, to fight for the board even to meet. The board did not meet between January and May of the pandemic last winter and spring. And it was something that was weighed heavily on my mind as a public member who felt obligated to take action and to not leave things to existing systems of emergency management, because we know that when we're in a rush, we rely on those old systems, and those old systems are not equitable. So I was really proud to be able to kind of get the board meeting again. And once we did, we had a very activist agenda. And I credit the Board of Health Chair, Joe Cressy, and Vice Chair, Kristen Wong-Tam, with keeping that activist agenda. Because when public health, who are leaders in health equity, they've been quite overwhelmed with dealing with pandemic response. And when there are any gaps in their health equity response, we are there as the board to keep pushing and to keep those matters on the agenda. And so in that intersecting way. And I can talk a little bit more about a few of our successes later on. You might have heard about, the collection and use of sociodemographic race and race-based data, reporting of COVID rates by neighborhood in ways that were not stigmatizing, transparency in reporting about workplace outbreaks. All kinds of stuff came because of the leadership of the board. And then also lastly, and I think Claire O'Gorman will be putting this into the chat box, that the city came up with what they call TO supports, a COVID-19 equity action plan that goes through public health, but also across the whole of municipal government to advance healthy public policy in an equitable way with a focus on disproportionately impacted communities right across that whole body of government. Investment in community and those community agencies in recognition of what they have to offer that no one else has to offer is a key component of that. And so it's those interrelationships that have really helped to keep health equity on the radar at the public policy level here in Toronto.
Thank you, Kate. And I think just thinking about Smita, what you said, and Kate, what you said, you can see at different levels, right, where that common goal, common agenda, if you will, is so important. And You know, Smita talked about making equity our new normal. Well, it's very interesting as you sort of track the recent history within that Toronto Board of Health. They are actually making and putting in place structures and policies that actually would support making making equity the new normal or the current normal. So well done. Thanks, thanks, Kate, for that example. And we will ask you to speak more to that. So Bonnie, over to you as our third. And again, you're sitting in a similar place, if you will, geographically, but a different place within our system and our public health system. So if you can introduce yourself, and then how do you, or how have you brought voices from community into your work inside that office of the Chief Public Health Officer? And why is community partnership or community engagement so important in terms of our way forward? Over to you, Bonnie.
Great. Thanks, Claire. And thank you, everyone. And speaking geographically, I'd first like to situate myself geographically and recognize that I'm on the territory, coming to you from the territory of Algonquin Anishinaabe people. And I'm so grateful for my work here and with Indigenous communities. As Claire said, I work in Dr. Teresa Tam's office, and my work specifically is to support Dr. Tam in the evidence development of her reports, of her annual report, her spotlight reports, and summarizing evidence for a science to action approach in her office. And so, you know, being at the federal level in a federal organization, I am not situated in community or in a neighborhood. And that is really important for me to say, because it has been a priority of Dr. Tam to really listen and bring community voice and voice of living experience to her work and to her reports. And so she made a very conscious effort in her mandate, which each Chief Public Health Officer has a 5-year mandate, to specifically include voices of people with living experience and community as a line of evidence in the reports that she produces, so that she looks beyond peer-reviewed publications. And this has been so important to Teresa. It's been very much Dr. Tam's style to listen and learn from local knowledge, capacity, and leadership and networks, and really recognize that it is this leadership that we can work together and improve our system. At a previous meeting, it was Kate who actually said in a presentation that health equity is not implicit. And that is a very strong foundation in Dr. Tam's work. It has been a part of her, it's been central to her mandate, which is trying to contribute to health equity in Canada through her work. And really it's, that for us, that statement of health equity is not implicit has been just so thought-provoking and inspirational. And so it calls for us to bring together people with lived and living experience to help inform where we're going. But also Dr. Tam makes an effort to go to tables where she can listen and learn and bring advice together. And so Claire, you ask also why we do this, and with a health equity mandate, the answer is there's really no other option, and so equity, it needs to be, and what we're thinking about as far as COVID-19 in particular. Dr. Tam has often said that COVID-19 has jolted the consciousness of the general population. For me, it's so great to see people on this call introduce yourselves, and I think a lot of us have been working on health equity for quite some time. But now during COVID-19, the general population's awareness is jolted around the importance of us protecting everyone so that we can move through this pandemic. And to be able to, we're thinking of the COVID-19 response, as you said, Claire, but also recovery and preparedness moving forward. And if we're really to be ready for the next pandemic or health emergency, which is going to come, all of us on this call are aware that we need structural changes to be able to get there. And it is only with community that we would be able to do this. A colleague said to me earlier this week that there's no public health data. There's data that is used by public health. And throughout the response, it's been really hard to not have access to the data that we need to bring evidence to bear. And when Toronto Public Health, for example, and Ottawa Public Health are releasing disaggregated data for us to actually be able to learn what's happening in communities, that's the start of what we need to know, and it's really what Dr. Tam has been leaning on, and one of the missions of really trying to move forward. So, you know, as we go into recovery and preparedness for the future, then what are those structural levels of change, and how can we work together? What are those health equity indicators that we can have so that we are socially and economically ready for the next pandemic as well? And I'll just end on another why. One of the areas of work that Dr. Tam talks about as well is, as we move forward, it's incumbent upon us in public health to open up our traditional pandemic influenza plans, and, you know, really take that traditional way of working apart and put it back together again in a way that makes sense, that doesn't focus just on health risk, but social and economic risk for health. And so that we're also incredibly inspired when Toronto Public Health voted on a health equity approach and to create health equity indicators for moving forward. And we can only do this with community if we're actually going to do it well together.